get additional government incentive funding for something they're likely going to be doing anyway. So with that, I'd like to talk about meaningful use today and the government regulations in adopting EHR. One thing I do need to mention is because I am the founder and CEO of an EHR company, I do want to let you know that the information I am sharing with you is not as representative of Medicare or CMS, even though, as Gwen mentioned, I am the liaison with the ACA for this. I'm not representing the federal government in sharing this information. I am representing Future Health with you today. And what we're going to go over is just 5 minutes on the concept of EHR so that it's not just about the government incentives, and then we'll get into actually how the money is calculated. I'm also going to go over the national statistics, the most recent statistics released by the government on the monies that have been paid to chiropractors so far throughout the United States, and we'll talk about some of the considerations you might want to evaluate in adopting EHR into your practice. Now, in the surveys that I've done at colleges, at state associations, and we asked doctors to raise their hand, I'd say that 1/3 to 40% of the profession raises their hand when it comes to buying an EHR, but what you're going to find is implementing the EHR is another story. It's actually the #1 concern that DCs have is, how do I implement this into my practice? Well, as a comparison, about 4 or 5 years ago, when I had the opportunity to climb Mount Kilimanjaro with some other fellow chiropractors, I can tell you I'm not the mountain climbing type. So if it wasn't for the proper planning, the training that we did for 3 months prior to doing it, and then having numerous guides going with us, and the teamwork and the support from the other DCs encouraging you to keep going, there's no way I could have done it without those steps. And so what I'm saying is, you can implement an EHR as long as you just plan it out, create enough time for adequate training, and keep a positive attitude with your team, and you can achieve it. It's not as difficult as it might seem. Just make sure you've got the right partner behind you to show you the way. That's really what it comes down to. And with EHR technology, you can achieve practice success faster. There is no question that you'll achieve other benefits to your practice besides this government incentive. And another question that's often asked is there a difference between a chiropractic EHR and a medical EHR? And quite frankly, there is no such thing. An EHR is an EHR. It's an electronic health record. Now, it's true in the documentation component, having chiropractic templates or having chiropractic nomenclature all preloaded for you, certainly there is a difference, and you do want to have that because most doctors will tell you the EHRs designed for the medical community doesn't fit the workflow of a chiropractor, making it much more difficult, much more time consuming. So all of the benefits surrounding an EHR, besides meaningful use, which is going to be the bulk of what we speak about here today, but it's really about the health information exchange. It's about sharing information with your local hospital when you are caring for a patient together, or your diagnostic center when you're getting that MRI report or blood lab results, so you don't have to mess around with the old ways of requesting information, faxing forms over. It's about the ability to go get that information in a timely manner that benefits your patients. You know, you might recall the old days of requesting an x-ray on plain film. It could take a week before those x-rays showed back up into your office, and then we move towards the discs, the CD-ROMs, where patients come in and have their MRIs on a CD-ROM. Well, today and moving forward, 5 years from today, all of that is going to be ancient history. It's going to be about the interchange and immediate access to health information on your patients, so you can make decisions about their healthcare at the time of service that impacts what's going to happen with this patient and getting immediate results. Besides other benefits like minimizing errors, there's also office efficiencies. My own practice, I used to have 31 full-time staff because we had an interdisciplinary practice with medical doctors, chiropractors, physical therapists, acupuncture, massage therapy, all of that. And we were able to minimize that down to 21 employees. I'm not going to say that reduction was all due to the software, but 6 people were eliminated because of the efficiencies of the software. We used to have 5.5 people doing our billing in a multi-million-dollar practice, billed out annually, and that practice to this day continues to bill more than that with only 2 full-time billers doing all of that because of the efficiencies. Now, let's talk for a second about the difference between EHR and documentation. The electronic health record really is the all-encompassing software to manage the entire chart of the patient and connecting you to the billing, the documentation, the patient education, and the scheduling. To interconnect that office is what's key. But documentation is one key component, and that's not the EHR. That's just your daily notes and your exams and things of that matter. But when you stop and think about it, most doctors, when they're choosing to get an EHR, the number one reason in surveys is they're choosing an EHR because they want to improve their documentation, they want to pass an audit, they want to get paid for the services they render, and they know they need better documentation to do it. So that's their motivation to move to the digital world. But I want you all to understand that an EHR is much, much more than just the documentation. But when you are being scrutinized by the outside world to determine if you should be paid, your state board, the first thing they look at is your notes whenever somebody complains about you. Your insurance company, what do? When they're determining medical necessity, they request your records. What does Medicare do? They request your records. So it's your records, your documentation that you are being judged by. It makes no difference if all your patients love you and all your patients say you're a great doctor, and let's say you are an A+ adjuster and diagnostician. You can be the greatest doctor in the world, but if your notes are chicken scratch, and if your notes are substandard and not according to the minimum standards that your state board license expects of you, then you're practicing below the standard of care. Then your notes will be denied and your care will be denied, and the quality of your care is being looked upon as substandard. So even though you're an A+ person and your patients love you, the fact is the outside world doesn't think so. They give you a D+. So if you're interested in seeing what a digital note can look like from an EHR, you can go to www.freesamplenote.com, freesamplenote.com, and you can download what a note looks like from our system. And what we did is we had 3 experts in chiropractic who lecture nationally about proper documentation. And we got their feedback and we wrote some things down in red on the note just for some little tips that they pointed out, and they've evaluated this note for a passing grade. So let's get back to EHR now. Currently, a little over 1/3 of the profession has adopted an EHR, a certified EHR. Now, a number of those, however, have not fully implemented it. So it's estimated that approximately only 20% of the profession has actually implemented and are actively using an EHR. The other statistics from these surveys are showing that another 40+% are actually planning to this year and next year. And so that by the time 2015 rolls around, 85% of the profession will have adopted an EHR. And this also is consistent with CMS estimates across the board for all physicians for adoption rates. So back in 2009, when ARRA, the American Recovery and Reinvestment Act, was passed, inside the ARRA Act was the High-Tech Act. And the High-Tech Act specifically dealt with $19 billion geared for giving to all eligible providers monies for those who adopted and successfully used an EHR. And the 5 eligible providers are MDs and DOs, dentists, podiatrists, optometrists, and chiropractors. Notice how they've all listed them as doctor of something, and of course they listed us as chiropractor, a good old CMS. Now, the American Recovery and Reinvestment Act is nothing to do with national health care reform. So for those of you still waiting for a repeal of national health care, the High-Tech Act has nothing to do with that. It's completely funded by the Federal Reserves, so it's not even part of the CMS budget. It's outside the CMS budget. So it's moving strongly ahead, and you'll see on some of the slides coming up the millions that have already been paid, billions that have already been paid out. Just to give you a little quick background, it all started back on January 1st, 2011 was the first time meaningful use started. So it's been over 2 years already. Now, you could get $44,000 per eligible provider if you started in 2011 or 2012. Well, now that we're in 2013, the most you can get is $39,000, okay? Now, you would have to start by October 3rd, 2013 in order for you to get up to $39,000. So you've got time. You've got several months here to still get 39 grand. Meaningful use is specifically defined by the federal government, and the purpose of it is for them to get doctors to collect data on patients. You're not going to share specific patient data with the federal government. You're sharing percentages of data that you've collected. What percent of your patients did you collect this on? What percent of your patients did you collect vital signs on? So you're giving that kind of data, not specific protected health information on an individual patient. There are 3 phases, and we're in phase 1 right now. And for those of you on this call who have not yet started meaningful use, you'll be in phase 1 for your first 2 years. So phase 1 deals with the data capture. Then starting later next year, for those who've been in the program for a couple years already, they'll start having a couple additional meaningful use items to do advanced clinical processes. And then eventually in 2015, the goal is going to be getting improved outcomes. That's the result here. They want you to have data in front of you so you can make clinical decisions with data immediately available to improve patient care, getting better results and better outcomes. And therefore, in the long run, it is estimated that EHR adoption will save the federal government $77 billion annually. So that's why the government is giving out $19 billion to get us all to adopt, because they're going to save $77 billion over time. Now, in order to participate as an eligible provider, you are a DC, you do need to be a Medicare provider. That means you need to be enrolled in PECOS, P-E-C-O-S. You can't be in Medicare unless you have enrolled in PECOS. You'll then go to the CMS website, and I'll give you the link to that in a moment, and you'll register for the EHR Incentive Program. And when you register for the program, you basically set up your own account, and that account will be good throughout the 5-year period that this is going on. And you need to make sure you have your NPI number when you're registering, and you'll also need to know if you're going to have the check assigned to your tax ID or not. Now, good news is you don't even have to own an EHR to go register. You can register now for the incentive program, and you don't have to identify what EHR you're using until you actually attest at the end of each reporting period, at the end of each year. So I suggest you go to the CMS website, specifically right here, this one here, ehrincentives.cms.gov/hightech/login ChiroMatrix.action. That will take you directly to the correct page within the CMS website. Save that and go ahead and jot this one down here. And again, you will need your NPI number, and then the password is related to the same password you used when you created your NPI number. If you don't recall what that was, there's a link on this page to go request it straight from Paycos. So you might need to do a little organization administration there to get your account set up. And once you've got that, each individual doctor will have their own account separate, more than likely. Therefore, if there's two doctors in the same practice, you're both eligible for the $39,000 each, even though you both use the same EHR. And if you want to take a look at which EHRs are certified, you can go to this website, and this is from the Office of the National Coordinator, who certifies each EHR. So the example I've listed here for you is our own, Future Health, and this is our certification number here, because when you attest, you'll need to put that number in for attestation. And attestation is at the end of your reporting period, you're going to answer a series of questions at the same registration location when you're done at the end of each year, and you'll put in your answers, submit it, and they'll tell you successfully submitted, and it's an 8-week period to getting your check. And we're going to go over the details momentarily. This is another screenshot from the ONC website and shows you how it lists the different vendors and their version of certification. So at this time, I'd like to ask a little question, and I'm going to ask Gwen's assistance here, if we could launch a poll. And I'm curious, for those of you who are on this call, how many of you are using a certified EHR presently? So if Gwen wants to launch that poll, I'll take a look here, and looks like we are.
Very interesting. It looks about a even split, 50-50 between those who are using and those who are not, as you can see right there.
Yes.
Interesting.
Yeah. So the other curious thing, we do have questions on your GoToWebinar panel on the right side of your screen. There is a box down below to submit a question. Feel free to submit questions, and I'll answer them towards the end. I may answer them throughout. I'll be glancing over at them, so feel free to submit a question on the material that I'm covering. You just type it in, and I'll respond to those as we move forward. Okay. So looks like the poll is closed, so I'll keep moving forward. Here's a little summary of the requirements to get your EHR incentive payment. Obviously, you need to choose and adopt and implement a certified EHR product. Then you're going to achieve meaningful use, which we'll cover. And CMS is going to pay you. If you're wondering how do they pay you, they're going to pay you based on a formula of 75% of the Medicare allowed charges that you submitted in the calendar year. So for this year, for 2013, your first year, you only have to do meaningful use for 90 days, 90 consecutive days. So let's say you start October 3rd and go to the end of December. Or let's say you start August 1st and you go till October 30th. And as long as that's 90 exact calendar days, you would then at the end of that 90-day window, you have a time frame to answer a series of questions on the website inside your account for each meaningful use measure, and you'll attest or solemnly swear what you achieved. And your software is going to tell you the numbers, what percent of patients did you do this on or that on, and you'll have scorecards to help track this for you. And the formula then for the check to be issued to you is going to be based on, even though you did meaningful use for 90 days, you're going to be allowed to use the full calendar year of January 1st, 2013, all the way through the end of this year, December 31st, 2013, all of the charges that you submitted to CMS, and the only allowed charges are the CMT adjustment codes. So there's only 3 codes that it's going to be based on, but it's not what you were paid, it's what was allowed to be charged that you submitted. So let's say you're allowed to submit a $35 charge. Let's say they only pay you $31. They're going to go off the 35 allowed submitted charges, that total, and then they're going to take 75% of that to come up with your payment amount for that year. And then each year thereafter, they'll do the same thing next year, but they'll use the data in 2014 for your 2014 check. Now, on this 75% rule, you also need to know that there are maximum amounts. So for those of you with large Medicare practices where you might have $50,000 billed of allowed submitted charges in the calendar year of 2013, they're not going to pay you 75% of $50,000. The maximum cap for 2013 first year doctors is $15,000. Now, the other thing I want you to know that is if you don't get started by next year, October 3rd, 2014, there won't be any money available. So let's use this chart to kind of show you. So the doctors who've already started back in 2011, they could have gotten 18 grand their first year. Same thing last year, if it was the first year that doctors started, they could have gotten 18 grand in their first year for just 90 days of work. Now, for those of you on this call, half of you have already attested. So that to me says chances are you've attested and you have the potential to get up to 18 grand for 2012. For those of you, half of you on this call who haven't started yet, the most you can get this year for 90 days of work is $15,000. Now, how much in allowed submitted charges would it be? That 20 grand. So 75% of 20 grand is 15 grand. So if you billed to Medicare $20,000 in allowed charges in this calendar year between now and the end of the year, if you build 20 or more, you'll get the full $15,000. For those of you who have a smaller Medicare practice, and let's say you only have $10,000 of submitted charges in the calendar year, then 75% of $10,000 is $7,500. So you would get $7,500 in your first year. And then you can see how the dollar amounts decrease over the next 3-4 years. And then it comes up with your totals here. So again, I'm going to go back to my statement I made a moment ago. If you wait until October 3rd, 2014, let's say October 4th, 2014, and you wait October 4th or after 2014, you get zero. You've got to be implemented by next year, October, to get at least 24,000. For those of you who implement by this year, October 3rd, you can still get up to 39 grand. So as you can see here, the big money's in the first couple of years, okay? So how do you get paid? Well, you're going to be paid in the exact same fashion that Medicare pays you today for your regular Medicare services. If Medicare actually issues you a check in the mail, then that's how you'll get this check. It's a one-time check each calendar year, and they process the claim usually in March and April of the next year for the prior year. Why do they do that? They do that for doctors who didn't hit the maximum amount. Because the year ends December 31st, they give you to the end of the year to get your full maximum possible of submitted charges so that they're not going to come back and make up for it later and give you a second check. They're going to issue one check, and they give you till the end of February to get all your charges submitted for the prior year. So you have till February 28th to submit all your charges for 2013, and then they'll process the check, and it's usually a 4 to 8 week check processing time frame. So in the springtime, like right now, many doctors are getting their checks right now for 2012. Now here's the exception of how you could get your check faster. You could get your check faster if you hit the maximum already. So for example, if you do $20,000 in submitted charges, and that entitles you to your full 15 grand for this year. If you do your 90 days, let's say this summer, July, August, and September, you do your 90 days this year, and you've already billed by the end of September over $20,000, well, they'll process your check right away. They won't wait till the end of the year. You'll get your check probably around November of this year for 15 grand. I do have a couple questions I'll answer. Will we be able to print a copy of the PowerPoint after the webinar? Here's what we will do. We'll give you a summary of this webinar. It won't be the PowerPoints themselves, but we will give you a summary. You just need to contact futurehealthsoftware.com. Go to our website. There's a registration there, and we can give you a summary of some of this information here. Another question is, you're saying that this is only valid if you are a Medicare physician. I am not. Will I be forced to participate even if I do not want it? So let me go into that for a moment. So if somebody's not a Medicare participant, what that means is this doctor has determined they refuse to see any human being over the age of 65. So any doctor who is not participating in Medicare cannot legally see any patient who is on Medicare. So that means human beings in the United States over the age of 65 and people under the age of 65 who are on Medicare, this doctor could not treat them legally. And in that case, then no, you wouldn't even get one dime because the formula is based on your Medicare submitted charges. However, everybody needs to know this key fact. Even though your payment method is based on Medicare submitted charges, you are actually performing meaningful use on all of your patients that you see in the reporting period. So you're not just doing meaningful use on Medicare patients, you're doing meaningful use on every human being that you see in the reporting period. So in the 90-day period, all the patients that come into your office that you have an encounter with, you're supposed to attempt the meaningful use criteria that I'm going to go over with you shortly, and capture that data on them. Now, you don't have to be 100%. Many of the meaningful use criteria is 50%, 80% on some of these items. None of them are 100%. And so my point here is you're being judged on all the patients you see in order to be eligible to be paid on it, but the formula for the dollar amount that you get reimbursed is based on Medicare submitted charges. So the other question is, will I be forced to participate? At this time, nobody is being forced to participate. There are penalties for not participating, and I'll go over those in a little bit here. The penalties are on your Medicare payments, so if you're not a Medicare participant, your penalties actually are zero. So let's go over some data. This is the most recent data available. They only publish this quarterly, and so currently, here's what we've got. We've got chiropractors, 1,981 chiropractors have actually been paid for successful, meaningful use. Now let's look at the dollar amounts. $28 million has been paid to chiropractors. So in the first year, $18 million was paid. Now as of January, $9 million was paid for 2012. But remember, folks, that would have been for the earlier people only making 2012 their first year. So there's going to be likely another 20 to 30 million being paid last month, this month, and next month for 2012. So we'll easily be over $50 million by summertime for the 2011 and 2012 program in total that will have been paid to DCs. And then you'll see an even larger amount for 2013 because remember, those who started in 2011 are going to get another check for 2013, and you're seeing larger adoption now in the 2000 year. Just so you know it's real, I decided to include some checks of doctors. Here's a 2-doctor office, 2 doctors in the same office. Their check was $36,000 for 2 providers. Another doctor had $18,000. He got the full amount. He started in 2011, got his check on March 8th, 2012. Same thing here. Another doctor got the full $18,000. So it is real. Okay, it is real. So let's do a poll question, and while we're doing the poll question, I'll answer other questions that have come in. So if Gwen wants to go ahead and launch the poll, we'll do that. Have you successfully attested for meaningful use? So you might have an EHR, but have you successfully attested, completed it, and gotten a check? I'll answer some other questions while the poll is occurring. Someone says, I have a DC and PT. Is it a combined total of both disciplines? Unfortunately, physical therapists are not included as an eligible provider. You may recall on one of the earlier slides, the MDs, DOs, dentists, podiatrists, chiropractors, and optometrists are the only eligible providers. So PTs are not included. And when you submit, you're only submitting not for the clinic, you're submitting for that individual doctor and the patients that that doctor saw. And so someone's asking, is it per doctor or practice? It is per doctor. Okay, you're not submitting clinical data, you're submitting data, and your software is going to track you by individual doctor. Okay.
So, Dr. Kraus, we went ahead and closed the poll for that one.
So yeah, the statistics there. For those who bought an EHR, obviously most of you have not started with meaningful use yet. Most of you on this call, 97% of you, have not actually attested yet, or you haven't gotten your check yet. So most of you are new to the program. That's helpful to me. So what's required to achieve meaningful use? Well, there's kind of 2 categories. There's what's called core objectives and menu set objectives. So there's 15 core objectives and there's 10 menu set objectives. Of the 15 core, DCs are excluded from 2 of them. We're exempted from them. So we have 13 that you have to do. And of the menu set, all eligible providers are supposed to pick 5 of the 10. You get to select which 5, even though a couple you are kind of required to pick what's in the scope of your practice. So it's not a total free-for-all. And one of them, it does have to be a public health measure. So 13 plus 5 is 18. There's 18 things that you have to do during the reporting period. And so this document you see here, one of the other persons who wrote in said, hey, is there a summary of this presentation? And one of the things that we would provide to you is this summary that Future Health created. And this is a document that we developed in a 1-page to summarize the 13 of the 15 core items. And then we have another document for the 10 menu set items. And what we've done is we've described the core objective right here. Then we describe the measure, what percent, and if there's an exclusion. So any doctor on this call who is from the state of New Mexico, Oklahoma, or other states that you are allowed to do injectables or do some limited prescription, then you may not be excluded from items 1 and 4, because if you had over 100 prescriptions, then you would have to do those as well. But 99% of us likely on this phone call, on this webinar, do not do prescribing, and therefore you are excluded from 1 and 4. But let me give you an example of how easy it is to achieve this. We've helped several hundred DCs achieve meaningful use. And we've gotten rave reviews because what we've done is we've taken every single core objective and every menu set objective and broken it down, showed you how to do it, and 90% of these items will be done by your staff. So doctors, it takes about 8 hours of training to get one staff person fully trained on every single item inside the software, to know it inside and out and to understand all this meaningful use criteria. And my suggestion to you is to bonus your staff person, whatever it is appropriate. Maybe it's a percentage of the overall check, and they'll love it, and they'll make darn sure you achieve meaningful use. And we have a meaningful use hotline, and we have a whole meaningful use training center to teach our doctors how to do this. And once you get through the first 90-day reporting period, I can't tell you how many doctors have told me that in the second year, in 2012, they don't even realize they're doing it. It's just part of their practice, and it's not a burden. It's not an extra hassle. As a matter of fact, they all feel like they're providing better care because once a year, you need to get the blood pressure, height and weight, and vital signs. You don't have to do it every visit. You just make sure you got it in the reporting period at least once. Obviously, if the patient's health condition changed or got modified or a whole new condition happened, you might want to update it, of course. But the other pieces are just capturing the demographic data. It's capturing smoking status, capturing their medication list, their allergy list. It's something you can do very easily with a special form we designed that your patients will fill out, your staff will enter it in, and you only have to do it once in the reporting period to capture it. And then when it's time for your second year, well, you've got all the data in there. It's just a matter of updating it. So let's do some high level here. As we've said, 13 of the 15 are required. And let's just do a couple more examples here of the menu set. So this is the menu set. There's 10 items here. You would choose 5 of these items. Most of these items, folks, of the 18 total items you have to do, 8 of them are one time, not on each patient, but just one time in the whole reporting period. For example, you would create on item number 3 here, you would generate a list of patients by a specific condition to use for quality improvement. Here's how you would do that. You would print a list of all patients who have the diagnosis of cervicogenic headache, let's say, or pick an ICD-9 code. I don't care what code you pick, but pick a code that some of your patients have and generate a list. Once you demonstrate that your software can do that, you've passed that meaningful use measure. You're done. It's a one and done. And again, we've created a checklist for these items to guide your staff in doing these measures and documenting what date they did it and how they did it. Another example on this one would be sending reminders to patients for preventative follow-up care. So you only have to do this, if you come over here, you only have to do it on 20% of your patients over the age of 65. So, or you could choose the patient group under the age of 5. So take your it's something you should be doing anyway, right? It's a practice management builder to send a reminder to patients to come in for their next monthly visit or whatever your frequency is. You don't have to do it on each visit, but let's say they're scheduled for a preventative visit down the line, a month or longer, and you just either call them, mail them a postcard or whatever, but you're reminding them, and the software will generate a list for you and tell you, and then when you do call them, you just click the button saying you've done it. And as long as you did that on 20% of your patients over the age of 65, you've passed that meaningful use measure. And it's something that's a good thing for you to do anyway. Now, these are examples that it's not that difficult to achieve. If you would like to obtain this summary, go to www.futurehealthsoftware.com, and we'll do 2 things for you if you schedule yourself for a demo. We'll give you those documents, And in addition, we will also give you a $500 gift credit towards the purchase of any future health uh, package um, if you're a ChiroMatrix client. So that's our thank you to ChiroMatrix for partnering with us as a benefit to you. So that's www.futurehealthsoftware.com. Now let's let's cover just a couple of additional things, and I'll hit some questions. Please understand that Medicare is not accessing your EHR. Medicare has no method whatsoever to dial into your EHR and look at your records and your data. And when it's time for you to attest, you're filling out the answers and providing data to their questions, but you got the data from your EHR. And again, the scorecard of the EHR will provide it for you. It's not like you have to tally this up and calculate the 20%. The software is calculating these things for you. So throughout the reporting period, you'll look at your scorecard each week and see how you're doing on the measures. And the scorecard will even tell you exactly which patients you've done it on. So please understand that your data is your data and you own it. So we've already talked a little bit about the maximum amount of money you can receive. 39 grand is the maximum you can get by starting this year. It makes no difference if you're participating or non-par, and I'm not talking about participating in Medicare, I'm talking about how you get your checks. Some doctors are par, which means Medicare sends you a reimbursement check for the services you provided to a patient. Non-par means you collect a check from the Medicare patient and Medicare issues the check to the patient directly. So either one of those, you are eligible for this program because you are a Medicare participant. Again, the only doctor who's not eligible is if you have refused to see human beings over the age of 65, then this program is not for you. You're not eligible. Again, as a quick recap of the dollars, you can get up to 15 grand this year, up to 12 grand next year, 8, 4, for a total of 39. For some of you who may have started last year, you've got an opportunity to get 18 grand and still get 12 grand this year. So, it's real money. And if you think about the cost of new hardware, the cost of a software, this easily, the first check pays for your software and hardware. And therefore, the rest is gravy train. And it's something you'd probably need to upgrade to anyway. I'm going to say this. I actually don't understand why anybody wouldn't migrate to an EHR. I will say this to you. If the reason you're going to go adopt an EHR is for this government incentive program, you're doing it for the wrong reasons. You should not get an EHR if you're going to do it just to get the incentive money. It's not the reason to do it. The reason to do it is to manage your patient base better, to have better data on your practice, to have alerts and reminders for better patient care. The reason to do it is to create better office efficiency so your staff is more efficient, so your records are immediately accessible by any staff or doctor that you determine to authorize to have that access in your practice. And quite frankly, digital records are safer than paper records. If you have a fire, a flood, or a natural tornado disaster or something, or a patient or a rogue staff member decides to steal a file, it's gone. You don't have a copy of your paper charts. You have no backup. Digital records, you have a backup. You're not going to lose your data. Digital is safer than paper by far. We've already covered these financial examples here. So there is a phase 2. So if you start hearing about phase 1, phase 2, for those of you who are getting started, you don't even get into phase 2 for 2 more years. We've already analyzed phase 2. I have an article published on it. There's only 6 additional items in phase 2, and most of those are just little additional things to existing ones that are already there. It's no more cumbersome at all. I was surprised. So there's not a huge change in phase 2. Just 2 items there is. Nothing for you to worry about for 2 more years, because no matter when you start, if you start 2013 or 2014, your first 2 years, you will do phase one. So right here, 2013, you'll do phase one. You'll do phase one again next year. And then you would do phase two the following 2 years. For those of you who start in 2014, you decide to wait till next year and you only want 24 grand, you'll do phase one for 2 whole years. So you don't need to worry about phase two at this juncture. But to let you know, here's the difference. We said before that there was 15 core objectives in phase one and 10 menu set items that you pick 5 for a total of 18. Here, there's a total of 20 objectives, but as DCs, you're excluded from 2. It's still 18. It's the same. It's just that a few of them changed. So at this point, let's do another poll question, and I'll answer some of the other questions being submitted. Would you like to learn more about the EHR and ARRA incentive? Yes or no? Is there something we can help you with? So while you're answering that question, I'll answer some others that have come in. You said 15% of chiropractors are opting out of implementing an EHR. Can you do that if you are an in-network provider for insurance, including Medicare? So let's be clear. When I say opting out, it's not like it's a legal method of opting out. I should have just said choosing. They're choosing not to get an EHR. And why would 15% of the profession choose not to get an EHR? Reason number one, they're retiring within the next 2 years and they don't want to go through it. Number two, they don't see any Medicare patients whatsoever, and they don't understand the benefits of digital technology. So you do raise, whoever submitted this question, you do raise a very interesting point, however. If you're an in-network provider for insurance, here's what we're seeing across the country in the medical field. This has not penetrated the chiropractic field yet, but in medical, a couple of states have actually passed in their state licensing law. Part of their required continuing education is meaningful use, and in order to practice according to the standard of care, you need to achieve meaningful use. So their standard of care to maintain a license does include it. On the other hand, insurance PPO networks are also starting to state, again, this is medical, not chiro yet, but some medical PPOs are saying you can't be on our panel of HMO or PPO providers unless you have an EHR. They didn't say you had to do meaningful use, they just said you had to have an EHR. So another question here. I guess that was it. So implementation keys to success. Folks, I can't tell you enough. You know, we've helped over 3,000 clinics with an EHR, and we've helped another 800 or so doctors get going with, actually we're over 1,000 now of doing meaningful use. 700 and some have successfully received their check already of our customers, and a whole bunch have started again this year, another few hundred. So there's over 1,000 of our customers we've helped with meaningful use. As you can see, the majority of doctors in the United States doing meaningful use happen to be our clients. But here's the number one thing. It's all attitude. You got to find a champion in your practice, a staff person who's going to be into this. Right now, I can rattle off about 6 or 7 clinics out there who have mastered it so well, they've actually opened up their own consulting to consult to other doctors on how to do meaningful use. We've trained them so well. So my suggestion to you is go ahead and take a look for yourself, not only at the benefits of what an EHR can provide, but take a look at how easy meaningful use really can be. In my opinion, 3 to 5 hours of training for the doctor, 8 hours of training for the staff, and you're in it. And if you think about it, it's 90 consecutive days. So because of weekends, it's really 72 work days. And if it's not for you in the end, you know what, go get your first check. There's no rule saying you have to continue on in year 2, 3, or 4, but go get that first $15,000 check, pay for your computers and pay for new software for 72 business days of work. It's not hard, folks. And the tools we've created for you can make it even easier. So this is an example of one of those tools, the patient history form. So we created a special patient history form that asks a number of the meaningful use questions that you have to capture. The race, the ethnicity, preferred language, those are some things you've got to have. Some verification question, the medication list. We even asked the smoking questions. So we've designed this questionnaire to knock off 8 of the 18 in one shot. So this form right here handles 8 of the 18 meaningful use items. And then on top of that, remember what I said to you earlier, there's another 8 that are one-offs that you don't do on each patient. And then there's a couple other tougher ones. There's 2 or 3 that do take a little time of the doctor, but the rest is all done by the staff. And on those tougher ones, you're not doing it on each patient. You're doing it on about 9 patients because there's 9 clinical requirements that you just select, and you can hand pick those. This is an example of the scorecard inside the EHR. So for each measure, you'll pick which measure you're requesting. It'll tell you where you have to be. It'll give you an example if you have multiple providers in your practice, how you're each doing. So it does it by provider, and you can see on each measure how you're doing. And then you can have your staff monitor this. My suggestion for you is to do a weekly meeting with your staff during that first 3 months. Do an update, see where you're at, what you have to focus on, and you'll be successful. And again, these forms that I'm showing you right here, this specific form is the one we're willing to share with you that we created for our users. That health history form we would not be sharing. This is an example of a core measure. Record all the following demographics. Capture the preferred language, the gender, the race, ethnicity, and their date of birth. If you did that on 50% of the unique patients that you saw in that 90-day window, then you've met that measure. It's not that hard. Patients fill out the form, your staff enters it in. These are some of the menu set items, and we give you recommendations on which ones to choose, the ones that we feel are easier and simple to achieve, and we guide you in this process. So then what you'll do at the end of your 90-day period, you'll go back to that same CMS website that you registered. It only takes about an hour to go through the attestation process of answering a series of questions on each of the meaningful use measures. Thousands of DCs across the country have already done it. And as I said earlier, year 2 is a cakewalk compared to the first 90 days because you're in the groove. It's easy. You know what you're doing. It'll become part of your practice. And I want to share a really neat story with you. There was a doctor in Indiana. He's both a chiropractor and an attorney. And he called me up and he wanted to tell me this because he was so thankful for meaningful use. He said, you know, I always took blood pressure on all my patients when they come in as new patients or different adverse events. But I got to be honest with you, Doc, I wasn't taking blood pressure annually on all my patients. Some of my patients who I've seen for years, I haven't taken a blood pressure on them probably in 5 years. Well, because of meaningful use, I needed to get an updated vital signs on them. So I took their blood pressure. I had my staff actually do it and record it. And then my staff came in and they said, Doc, we've got a patient here with a blood pressure of 200 over 240. And the doctor said, that can't be right. Let me go take it. Sure enough, it was. He sent the patient to the ER. The ER doctor a couple hours later called him and said, you saved this patient's life. This patient was a heart attack waiting to happen. They were actually having major problems. The guy actually ended up getting sent out for heart surgery because he was like 99% blocked. Wasn't having a heart attack yet, but was having major problems. And that MD in the ER referred his own wife to that chiropractor because he said, you know, hey, you're one of the good chiropractors. and between all of us here on this call, why? He's a good one because he took blood pressure. But think about it for a second. It's the little things like that that make an impression on our medical colleagues, that we had the wherewithal to identify that. And as a result, that patient referred in numerous other ones. So the doctor who called me said he had 6 new patients in total over the next 3 months off of that one event. And he also told me, I know we don't have time anymore here on this call, but he also told me that he was able to, just by mentioning it, when patients said they were smoking, because he asked the question. Otherwise, he wasn't asking the question, do you smoke, on every single patient. And again, you don't do it every visit, folks. You do it one time a year. But because he asked the question and he documented in his EHR, he told certain patients to stop smoking. He said he had at least a dozen patients that he was able to get to quit smoking just because he had a 5-minute talk with them. And they quit cold turkey because he raised the issue. And they respected him enough for it. So meaningful use can be a practice builder, and it delivers better quality of care, and your patients will appreciate it. So with that said, you've got to choose the right partner to help guide you. You need teamwork within your practice. Adopt the right EHR, get your implementation plan, and we help you customize each plan. Execute that plan, train properly. Don't just train an hour or two, train the necessary time, and you'll successfully achieve meaningful use. And depending on the volume of Medicare that you see, my suggestion to you after this webinar is for each of you to go to your current billing software, have your staff print out a report on the 3 CMT codes, or just if you can do it by carrier to Medicare. Otherwise, try to find out how much in 2012 did you bill to Medicare. And if that dollar amount was 20 grand or more, you'll get, assuming you replicate that this year in 2013, you'll get your maximum 15 grand. But get an idea, is it worth it for you? And my answer to all of you is, if you can get at least 5 grand out of this program, it's definitely worth your time. And if you even can get $0, it's still worth implementing an EHR for the practice benefits, but you'll have to evaluate and make your own business decision if it's worth the energy to submit to meaningful use. So there's definitely benefits no matter what for an EHR, but whether you decide to participate in the meaningful use program really depends on the volume that you have. So let's see if some more questions have come in here possibly. These are just some of the things that we provide as tools for our users. And if you would like to get a hold of us, again, here's our contact information at www.futurehealthsoftware.com. Again, please mention that you're a ChiroMatrix client so that you're eligible to get the $500 gift credit. If you want to receive that summary form of the meaningful use criteria, please ask for that, and we'd be happy to submit that to you. So with that, we appreciate it, and thanks for allowing us to work with you. And Gwen, if there's any other closing comments you have, please chime in.
Absolutely. Dr. Kraus, thank you so much for a great webinar. You know, I think that this is often a complex topic for chiropractors to grasp and understand, and I think that you've you know, broken it down here and shown just how easy it is and the many benefits. I mean, it's just an incredible webinar. So thank you so much for your time. And for those of you, you know, who are on here, you know, please take advantage of that gift credit that they're offering if you are in the market for a new EHR provider, because this just has obviously so many benefits for your practices. So in closing, just thank you everybody for attending the webinar today. We know everybody's very, very busy, and hopefully this was, I know this was worth the hour of your day to get this information. We will be sending up a follow-up email with some resources for you after the presentation, including a link to a recording of the webinar in case you want to watch it again and go through some of those different points. And with that, I think I'll wrap it up. Dr. Kraus, thank you again, and we look forward to hearing more about future health and the things that you can help these doctors with.
Gwen, thank you very much. It was my pleasure.
You're welcome. Everybody have a lovely day, and keep your eye out for the follow-up communication from us. Thank you again for attending, and we will talk to you later. Bye-bye.